Hi, I'm Dr. Chris Lewis, one of the chief educators here at Doctors in Training, and I want to welcome you to the Solid Anatomy lecture on the lungs. In this video, we're going to be covering the lung, the trachea, the bronchi, and the bronchioles. And we're also going to cover in this lecture blood supply, nerve supply, and even lymphatic drainage. Now, I'll be back later for a clinical correlation and the end of session quiz, but for now, I'm going to turn it over to our primary lecturer, Dr. John Phelan.
The function of the lungs is to oxygenate the blood. A healthy, normal lung in cross-section looks like a sponge. There are myriad air pockets surrounded by the walls of the bronchial tree. Elastin fibers in these walls makes the lung a very elastic organ. The spaces between the walls of the bronchial tree are collectively referred to as the interstitium of the lung. The interstitium is occupied by blood vessels, nerves, lymphatics, and connective tissue. The right and left lungs are separated from each other by the bilateral pleural sacs that surround them and by the mediastinum, which is the space between the pleural sacs. Superiorly, the cone-shaped apex of the lung passes through the superior thoracic aperture and extends about an inch into the neck to occupy the cupola, which is the dome-shaped portion of the parietal pleura in the neck. The base, or inferior end of the lung, which is adjacent to the diaphragm, is called the diaphragmatic surface. The medial surface of the lung, which faces the mediastinum, is called the mediastinal surface. The lateral surface, which is adjacent to the ribs, is called the costal surface. The right lung has two fissures visible on its costal surface. An oblique fissure, which divides the lung into a superior and inferior lobe, and a horizontal fissure between the superior and middle lobes. The right lung is shorter than the left because it is superior to the liver, which bulges superiorly against the overlying diaphragm. The heart, within the pericardium, bulges to the left, encroaching upon and reducing the size of the left pleural sac. Consequently, the left lung is narrower and lighter than the right lung. The left lung does not have a middle lobe, so its costal surface has only an oblique fissure separating the superior and inferior lobes. The cardiac notch is an indentation in the anterior aspect of the superior lobe of the left lung, corresponding to the position of the pericardium. Inferior to the notch is a thin, tongue-like process of the superior lobe called the lingula, which is the homologue of the middle lobe of the right lung. It slides in and out of the left costo-mediastinal recess during labored respiration. If your human anatomy course has a laboratory component, you may be asked to identify impressions on the mediastinal surface of embalmed lungs. The mediastinal surface is in contact with structures that include the pericardium, the aorta, and the esophagus. These structures form impressions that show the relationship of the lungs to these structures in the mediastinum. For instance, an embalmed left lung has a large concave cardiac impression corresponding to the adjacent pericardium. These impressions would not be seen on a fresh lung because the shape of the lung has not been chemically fixed. The lung is connected to the mediastinum by the root of the lung, which contains the structures that enter and exit the lung. These are the bronchi, which arise from the distal end of the trachea and bring air into the lung, the pulmonary arteries, which branch from the pulmonary trunk and bring deoxygenated blood to the lung from the right ventricle of the heart, and the pulmonary veins, which carry oxygenated blood from the lung back to the left atrium of the heart. And if you're saying to yourself right now, I was certain that oxygenated blood was carried by the arteries and deoxygenated blood was carried by the veins, how could I have been so wrong? Well, you're actually right, but the one exception to the rule is the pulmonary vessels. The pulmonary arteries carry deoxygenated blood, and the pulmonary veins carry oxygenated blood. It's the opposite for all of the other vessels in the body. Additionally, the root of the lung transmits small blood vessels, autonomic nerves, and lymphatics, supplying the lung tissue that will be discussed later. The root is covered by a sleeve of pleura. Part of this sleeve hangs inferior to the contents of the root to form the pulmonary ligament, which is an empty double layer of pleura. The visceral and parietal pleura are continuous with each other at the root of the lung. The hilus, or hilum, those terms are synonymous, and they're both singular. The plural is hyla, is the two-dimensional structure on the mediastinal surface of the lung where structures enter and exit the lung. If you examine the hyla of the lungs, you will be able to distinguish the bronchi from the pulmonary vessels based on the thickness of their walls, which are covered by cartilaginous discs. The bronchi are the most posteriorly placed structures in the hyla. The right main bronchus bifurcates into a superior lobar bronchus and a bronchus intermedius near the lateral end of the root. So both of these bronchial structures are usually observed in the hilum of the right lung. Often, a septum separating the middle and inferior lobar bronchi can be seen when looking into the bronchus intermedius at the hilum. In the hilum of the left lung, just a single main bronchus is usually observed, occasionally with a visible septum within it where the division of the superior and inferior lobar bronchi is beginning. The pulmonary arteries divide with and follow the bronchi. In the hilus of the left lung, the pulmonary artery is located immediately superior to the main bronchus. In the hilus of the right lung, the pulmonary artery is found just anterior to the bronchus intermedius, and a branch of the artery is found just anterior to the superior lobar bronchus. Since the superior lobar bronchus is superior to the main stem of the pulmonary artery, it is often referred to as the eparterial bronchus. A pair of pulmonary veins, which do not follow the bronchi, are usually found anterior and inferior to the bronchi and the arteries at the hilus of both the left and right lungs. More than two veins are often seen at the hilus of the lung, but ultimately they combine to form two pulmonary veins that run through the root to the heart. If you memorize these structural arrangements, you will be able to distinguish a right from a left lung just by looking at the hyla. The trachea begins just inferior to the cricoid cartilage, to which it is attached by the cricotracheal ligament at the level of the sixth cervical vertebra. The trachea is a flexible fibroelastic tube lined by ciliated mucosa and reinforced by 16 to 20 C-shaped cartilaginous rings that cover its anterior and lateral sides. The cartilaginous rings prevent the trachea from collapsing due to the negative pressure created within the trachea when a deep breath is taken or from a blow to the throat. The trachealis muscle, which is a smooth and thus involuntary muscle, spans the ends of the cartilaginous rings and forms the posterior wall of the trachea. The flexible trachealis muscle can bulge forward when a large bolus of food is passing through the adjacent esophagus, which lies posterior to the trachea. The trachea bifurcates into the right and left main bronchi at the level of the sternal angle anteriorly, which corresponds to the disc between the fourth and fifth thoracic vertebrae posteriorly. If you've watched the solid anatomy lecture on the mediastinum, you may recall that this is also the level of the transverse thoracic plane. Within the trachea, at its level of bifurcation, there is a posteriorly projecting, vertical, cartilaginous extension from the most inferior tracheal ring called the carina, which is Latin for the keel of a boat, which the carina vaguely resembles. The trachealis muscle continues inferiorly past the level of the tracheal bifurcation to form part of the posterior walls of the main bronchi, but becomes narrower distally until it ends before the level of division of the main bronchi into the lobar bronchi. Thus, the walls of the lobar bronchi are completely surrounded by cartilage. At this level, however, the cartilage is in the form of irregular plates rather than rings. These plates become thinner and more sparse as the bronchi divide further.
All right, it's time for a clinical correlation. Now let's take a break here and talk a little bit more about the carina and the trachealis muscle as they relate to cough before moving on with the lecture. Now, contact with the highly innervated mucosa covering the carina triggers a cough reflex that helps expel objects that would otherwise be inhaled into the bronchi. So this would include mucus if a patient happens to have an upper respiratory tract infection or maybe a foreign object as well. Now this serves as a defense mechanism for the body to expel mucus or that foreign object from being aspirated into the lungs. However, if an inspired object does enter a bronchus, it's most likely to end up on the right bronchus because the carina tends to kind of project towards the left, which blocks the entrance to the left bronchus, and because the right bronchus is wider and more vertically oriented than the left. And also the right bronchus is also a little bit shorter than the left one as well. So this first question is a real common test question, so be familiar with this concept. You're going to see it over and over again. If an inspired object passes the carina of the trachea, it is more likely to become lodged in the right or the left bronchus. And we just answered this. This is the right bronchus. Next here, and then we have the other thing that I wanted to discuss is the trachealis muscle. So this muscle is clinically important because it plays a role like the carina in the cough mechanism. This muscle contracts to narrow the lumen of the trachea during a cough, which serves to increase the velocity of airflow through the trachea. Now this increases the odds that the object causing the cough will be propelled out of the airway. The airflow in the central trachea during a cough has been estimated at about 155 miles per hour, so really fast stuff flowing through there. So that answers this next question. How does the trachealis muscle assist in coughing? Remember, it contracts to narrow the tracheal lumen in order to increase the velocity of airflow through the trachea. All right, guys, let's carry on with that lecture now.
The lobar bronchi divide into a total of 10 segmental bronchi in each lung. The inferior lobar bronchus of the right and left lungs yields 5 segmental bronchi. The superior lobar bronchus of the left lung also divides into 5 segmental bronchi, while in the right lung, 3 segmental bronchi come from the superior lobar bronchus, and the middle lobar bronchus bifurcates into the remaining 2. Each segmental bronchus enters a bronchopulmonary segment, which is the functional, anatomical, and surgical unit of the lung. The 10 bronchopulmonary segments in each lung are enclosed in and separated from each other by connective tissue septae. A surgeon may remove a diseased bronchopulmonary segment without disrupting adjacent segments. Each bronchopulmonary segment has a segmental bronchus and a corresponding segmental pulmonary artery. The branching pattern of the pulmonary artery mirrors that of the bronchi, but the pulmonary veins follow a branching pattern independent of the bronchi. The pulmonary veins draining the bronchopulmonary segments are intersegmental. That is, they run in the connective tissue between the segments and drain adjacent segments. A thoracic surgeon should know the names of the 10 individual bronchopulmonary segments, but anatomy students are typically not expected to do so. After the segmental bronchi have divided for another 8 to 10 generations, cartilage is no longer present in the walls, and the bronchial tree has reached the level of the bronchioles, which are surrounded by smooth muscle. This smooth muscle controls the airflow into the lungs. The bronchioles divide, remarkably, for about another 8 generations until the terminal bronchioles are reached. The definition of a terminal bronchiole requires some additional descriptive information about the bronchial tree. The bronchial tree, or airway, is divided into a conducting portion and a respiratory portion. The conducting portion is made up of divisions of the bronchial tree that bring air into the respiratory portion. The respiratory portion begins at the level where the alveoli first appear in the final branches of the bronchioles. The most distal bronchiole that has no alveoli budding from it is the terminal bronchiole. The most proximal bronchiole to have an alveolus in its wall is a respiratory bronchiole. The respiratory bronchioles divide to form alveolar ducts, whose walls are nearly completely occupied by alveoli and contain very few smooth muscle cells. A single respiratory bronchiole and all of the alveolar ducts and alveoli that branch from it are collectively referred to as an acinus. The alveoli, which have no smooth muscle in their walls, are the terminal portion of the bronchial tree. The alveoli are the sac-like endings of the bronchial tree whose walls are so thin that they allow gas exchange to occur. There are about 300 million total alveoli in an average lung, with a total surface area about equal to that of a tennis court. The outer part of their walls simply consists of the endothelial cells of the dense capillary network that covers them. The inner portion of their walls consists of two types of epithelial cells. Over 90% are squamous pneumocytes, which are involved in gas exchange between the blood in the capillaries and the air in the alveoli. The remaining epithelial cells are granular pneumocytes, which produce a surfactant that coats the inner surface of the alveolus and prevents it from collapsing. Carbon dioxide from the blood in the arterial end of the pulmonary capillary bed passes through the wall of the alveolus to be expired by the lungs, while oxygen from inspired air leaves the alveolus to pass into the blood in the venous end of the pulmonary capillary bed. We've established that pulmonary arteries bring deoxygenated blood to the lungs for gas exchange. The nutrient arteries of the lung, that is, the arteries that bring oxygenated blood to the lung tissues to keep the organ viable, are the bronchial arteries. The bronchial arteries usually arise from the thoracic aorta at about the level of the 5th or 6th thoracic vertebra. Their branching pattern is variable, but the most commonly observed arrangement is a pair of left bronchial arteries arising directly from the aorta and a single right bronchial artery branching from the intercostobronchial artery. Bronchial arteries enter the hilus of the lung and are usually so small that they are not observed during gross inspection of the lung in the laboratory. Branches of the bronchial arteries wind around the bronchial tree, following it down to the bronchioles. At this level are found extensive bronchopulmonary anastomoses and collaterals, that is, connections between the bronchial arteries and the pulmonary arteries. During typical lung transplantation surgery, the pulmonary arteries are revascularized, that is, their ends are sutured together, but the bronchial arteries are not. Blood will flow from the pulmonary arteries into the bronchial arteries through the bronchopulmonary anastomoses, thereby supplying the lung tissue, albeit in a reverse fashion. The bronchial veins have variable drainage patterns, but commonly the right bronchial vein or veins drain, usually indirectly, into the azygous vein, while the left bronchial veins drain, again usually indirectly, into the accessory hemiazygous vein, or the left superior intercostal vein, which drains into the left brachiocephalic vein. Interestingly, most of the blood supplied to the lungs by the bronchial arteries is not drained by the bronchial veins, but rather by the pulmonary veins via the bronchopulmonary anastomoses. Bronchial veins drain blood only from the most proximal areas of the lung and the bronchial tree. Nerve supply to the lung is autonomic and is mainly involved in the regulation of mucus secretion and the diameter of the bronchioles. Parasympathetic innervation by branches of the vagus nerve, which is the 10th cranial nerve, causes bronchosecretion and contraction of the smooth muscles of the bronchioles, resulting in bronchoconstriction. Sympathetic innervation by branches from the sympathetic trunk decreases bronchosecretion and relaxes the smooth muscles surrounding the bronchioles, resulting in bronchodilation. These nerve branches enter the lung at its hilus. Lymphatic drainage of the lung is variable, but here is a common pattern for you to memorize. Subpleural and pulmonary lymphatic vessels from the lungs pass through the hyla and drain into the following collections of nodes in order from proximal to distal: intrapulmonary, hilar or bronchopulmonary, inferior or carinal and superior tracheobronchial, and paratracheal. From this point, lymph drains into the bronchomediastinal trunk on the same side as the lung. The right bronchomediastinal trunk usually drains into the right lymphatic duct, and the left bronchomediastinal trunk often drains into the thoracic duct. These ducts deliver lymph to the venous system on the respective sides by connecting to the subclavian vein or another venous structure nearby. Here are two more facts about the lymphatic drainage of the lung to be aware of. Lymph may drain from the inferior lobe of the left lung to the right lung. And two, there is no lymphatic drainage of the alveoli.
So that completes the lecture on the lungs. Now I want you to pause the video and complete the end of session quiz questions, and then we'll go through those questions together. All right, let's get going. First question here: which bronchus is an aspirated object more likely to go down, and why? We've already gone through this. Remember, this is the right main bronchus because it's straighter, so more vertical. There's less of an acute angle to that bronchus. It's shorter, and it's also wider than the left side. Next question. When a person aspirates an object, the object will stimulate a cough reflex. How far must an object travel down the bronchial tree before the cough reflex is no longer stimulated? Remember, this is going to be past the carina. Next question. What is the name given to the part of the lung that extends above the first rib? That's going to be the cupula. Next question. What structures are always the most anterior and inferior at the lung hilum? That's going to be the pulmonary veins. Next question. What is the most prevalent type of epithelial cells found in the inner walls of the alveoli? So we have two options here. First, we have the squamous pneumocytes, sometimes also referred to as type 1 pneumocytes, and they make up about 90% of the cells in the inner wall of the alveoli. Now, there's also something called granular pneumocytes. Sometimes these are also referred to as type 2 pneumocytes. Now, remember that the squamous pneumocytes function to allow gas exchange in between blood and air in the alveolus. And the granular, or the type 2 pneumocytes, are going to produce what's called surfactant. And what is surfactant good for? It keeps the alveoli from collapsing. You can see a deficiency of surfactant in infants, especially very premature infants, and this will lead to respiratory distress syndrome, or RDS. Next question. Which lung is shorter and why? So the answer is the right lung, and this is because it is superior to the liver, which bulges superiorly against the overlying diaphragm. Next question. What are the fissures of the right lung? What are the fissures of the left lung? Well, the right lung has two fissures: an oblique fissure, which divides the lung into a superior and an inferior lobe, and then also has a horizontal fissure between the superior and the middle lobes. Since the left lobe does not have a middle lobe, it only has an oblique fissure separating the superior and the inferior lobes. Next question. Which lobe of the lung is the lingula considered to be a part of? That's going to be the left upper lobe. Next question. What is the homologous structure in the right lung to the lingula in the left lung? That's going to be the right middle lobe. Next question. What type of innervation causes the following effect on the bronchioles? So constriction and increased secretion, that's going to be parasympathetic. Dilation and decreased secretion is going to be sympathetic. Okay guys, we're almost done. Now we've provided some images for you to label. Recalling these images in a time setting will help you to perform well on the practical part of your exam. So label the images and then we'll be finished. Thanks.